Okay, so I hit the recording, so we're recording now. Like I said, you have another meeting at 11, so I'm going to jump in and we're going to zoom right through this. We're still on the immune system, will be for the rest of the quarter. And we'll be talking about cancer and HIV and COVID-19, but for this week, we're just going to cover some of the basic autoimmune type diseases. When we say autoimmune, lupus and fibromyalgia and rheumatoid arthritis are true autoimmune diseases. Gout's kind of the outlier. It's not really an autoimmune disease, but it has to deal with the inflammation in the body. So I've just included under the immune system as well. Moving on. Concept of immunity, the body's response to infection. Pretty simple, pretty simple. We're going to talk about autoimmune diseases, and you know, we've talked about and figured out how the white blood cells and the T cells and the B cells and all that, how they attack antigens coming into the body. Every once in a while, the body will get confused and it'll see parts of your body that should be there as the enemy, and it'll attack your own body systems. And so that's what we're going to talk about today. It's unfortunate we don't really have any cures for that. You know, for example, if a virus Staphylococcus aureus enters into your bloodstream, and your body mounts an autoimmune response against it. And the neutrophils and the macrophages and all that are attacking the Staphylococcus aureus. But then the indicators on the Staphylococcus aureus look exactly like the markers on, say, your joint tissue. Well, it starts to attack your joint tissue too. And it's just kind of a case of mistaken identity. For many years, we thought that's what rheumatoid arthritis was. We thought it was Staphylococcus aureus, and the little markers on the staph bacteria were very, very similar to the little markers on cartilage. So we thought, but I think they've gotten away from the idea that it's actually a Staphylococcus aureus. But we'll talk about that here in a minute. That gives you the idea of what basically what an autoimmune disease is your body just starts attacking itself. Multiple sclerosis is another one. We won't be talking about that today, but that's one where, you know, a little sheath on your muscle tissue, your body begins to attack it and break it down, and you lose the use of your muscles as a result of it. First one we're going to talk about is lupus erythematosus. There are different kinds of lupus. Actually, there's 3 flavors here. The discoid lupus is just basically just affects the skin and forms a type of rash. The one that's scarier than the discoid is the systemic lupus, because it will also affect your tissue and your organs. So it's definitely a more serious variety. And then there's sometimes you can get a form of lupus which is induced by medications, but as soon as you get off the medications, that goes away. So cure for that is don't take the medicine, right? Yay. But it's the SLE, the systemic lupus, that is probably the one you'll run up against the most. Who gets it? Females, 15 to 40 years of age. This is one of those, unfortunately, that targets females. Asian, Hispanic, and Africans are slightly more susceptible to it than, say, Caucasian. And you'll find this with a lot of immune diseases, autoimmune diseases. It's difficult to diagnose because we don't always have a test, you know, a lupus test. It's more a process of elimination, especially when it comes to disorders that involve fatigue, malaise, low-grade fever, achy joints. You know, as you can imagine, there's a lot of stuff out there, like nausea, vomiting, and diarrhea. You know, how many diseases do we have that cause nausea, vomiting, diarrhea? There's got to be 1,000 of them. So sometimes it's kind of hard to diagnose autoimmune diseases for that reason. I'll talk a little bit about more about that in a second. So here again, we go with expected findings: fatigue, joint pain, rash, fever, weakness, depression. These are all very symptomatic of somebody with lupus. If you've ever known anybody with lupus, you know, I can attest to a lot of these symptoms that they go through. Now, sometimes, not always, but sometimes those with lupus erythematosus, in fact, erythematosis actually describes this rash itself, they get what's called a butterfly rash, where the rash will go up on their forehead, it'll go out on their cheeks, and it literally looks like the wings of a butterfly, which is why they call it a butterfly rash. Now, if they do happen to manifest that, then that's a pretty good clue that that lupus is at the root of their problems. However, a lot of these other things could also be chronic fatigue syndrome, fibromyalgia, which we'll talk about. So there's just a lot of different diseases out there that have a lot of the same type of symptoms. If they do have the discoid lupus, they can do a skin biopsy. Dermatologists can look at it, and there is a lupus type cell in that, so they can diagnose the DLE pretty easily. As you can see, BUN creatinine, if the kidneys are involved, you'll see an increase in the BUN and the creatinine. The CBC, pancytopenia. Pan means everything, like pandemic. When we have a pandemic, it means a worldwide epidemic. So pancytopenia, cytopenia means low. So everything in your CBC is low. And that could be one of the symptoms of the lupus, is you are basically burning up your immune response. The one that you will most often see when it comes to lupus is the erythrocyte sedimentation rate, or ESR. That's a very common lab. You'll see the ESR around a lot. In fact, we'll usually refer to it on the floor as just sedimentation rate. And the SED rate's another way they abbreviate. Hey, what's their SED rate? SED rate are like the carcasses of the erythrocytes that your body is using up. And when those are elevated, that usually indicates that it's lupus that you're dealing with. But you'll often hear the doctor say, you know, they'll complain of the fatigue, joint pain, low-grade fever, and the doc will say, get a SED rate. So that's what they're looking at. Here again, I'm going to throw a term at you. It's called differential diagnosis. Have any of you ever watched House? It's one of my favorite shows. House is an epidemiologist, and they call Dr. House in whenever they cannot quite figure out what's going wrong with the patient. And he'll gather his little minions around him, and he will put up on the chalkboard differential diagnosis. And what they are basically doing is they write out everything that could possibly be caused by all the different symptoms that their particular patient has. And they go through them one by one, and they try to eliminate them. Once you've eliminated all of the other diseases, whatever you've got left is most likely the disease that they have. Another way of putting this is it's a process of elimination. And I will often give my process of elimination lecture to patients, because they somehow feel that when they come into the hospital or care facility, that we can take the little piece of blood and put it in this magic machine, and this magic machine will tell us exactly what they've got. I wish it was that simple. And you'll often have patients that are really frustrated because we can't tell them what's wrong with them. That's more common than you would believe, because there are so many different diseases and pathophysiologies out there that quite often we just have to run tests on what we think it is in a process of elimination till we hopefully find out what it is that person has. Now, this gets more and more difficult as patients get older and older and they have more comorbidities. If there's somebody that has heart disease, lung disease, diabetes, et cetera, et cetera, et cetera, those just makes it more complicated for us to try to nail down exactly what's going on with that person at the time. You know, why are they running a high grade fever? You know, there's already 14 things wrong with them, but what is the one thing that's causing that fever? Especially with autoimmune diseases, we don't have an autoimmune test. So more often than not, it's a process of elimination, especially when you're looking at something like chronic fatigue syndrome. How do we care for these patients? Well, since there is not a cure, we're basically treating the symptoms, palliative care. We're going to treat them the pain, treat them for the pain and the mobility, immobility, and the fatigue. You know, there's a variety of medications, which I'll talk about here in a moment, to help treat the pain. As far as mobility, we just have to get them up and keep them moving so that their joints don't stiffen up on them. Very much like with arthritis, you want to keep the joints moving. And fatigue, they just have to take things at a little easier pace, because there's really not much you can do to battle that. Anorexia can be one of the side effects. These people don't eat. So if they can just break their meals up into several small meals, it helps just to keep the nutrition going into their body, because they need that energy. There may be other manifestations: tachycardia, hypertension, renal compromise. We just use whatever medications we would use for those particular symptoms. May use a beta blocker for the tachycardia, blood pressure medications. There's a whole slew of blood pressure medications that we can use on them, which you got from last quarter. And renal compromise, there's some different medications we can use to help with their renal function. But basically, we're just treating the symptoms, not the disease. There again, NSAIDs, aspirin, Tylenol help keep the inflammation down. Corticosteroids, we've talked about those already. Solumedrol, prednisone. They are also an anti-inflammatory, help the joint swelling go down. One thing I wanted to point out, I probably didn't point out this before when we talked about corticosteroids, is never stop corticosteroids suddenly. They should, you should never stop them suddenly. Am I not having my little character? Oh, there he is. Okay. So I'll make sure I put my characters in there. There's a lot of withdrawal symptoms, a lot of bad things can happen to a person when they stop corticosteroids suddenly. Like hypertension and kidney function. Yeah. Immunosuppressants, methotrexate, you'll see that drug around. You might want to kind of put that in your little data bank. The azathioprine, I don't see that a whole lot more, but you do see methotrexate out there. And it's an immunosuppressant drug. Basically, if you get a heart transplant or a kidney transplant or whatever, your body's going to see it as a foreign object and it'll attack it. So as you know, whenever you get a transplant of an organ that doesn't come from your body naturally, you have to take an immunosuppressant drug to keep that drug from, or to keep your body from attacking that organ. We're kind of doing the same thing with this. For some reason, your body is attacking itself. So we can use an immunosuppressant drug to try to just kind of reduce your body's inflammatory response to itself, actually. But then again, when you are suppressing your body's immune system, you are opening yourself up for some infections. So these people have to be careful. Don't go out and mingle in crowds or whatever, because if somebody's fighting a cold, you're going to get it. They're fighting pneumonia, you're going to get it, because your immune system is suppressed. So that's one thing to watch out for on the immunosuppressant drugs. More drugs? Yeah, there's one more. they found that that an anti-malarial drug, hydrochloroquine, helps with the inflammation process, helps suppress the inflammation. And you guys might have seen that in the news lately. Certain people saying that hydrochloroquine will cure your COVID. And we didn't really have any scientific evidence that showed that it did cure your COVID, but people were taking it anyway. So it's been the subject of a lot of controversy during this COVID thing. And since everybody was trying to take the hydrochloroquine for COVID, there was not enough hydrochloroquine around to use for people who did need it. Like, we don't have a whole lot of malaria here in the United States, but we do use it for lupus and a couple other autoimmune diseases. So people with their lupus were having a hard time getting their hydrochloroquine prescription filled because of the idiots taking it for COVID. I'm sorry, did I say idiot? I shouldn't have said it that way. Anyway, I don't know if they've approved that for COVID treatment. I think last I heard they had not. Client education. With lupus, a lot of skincare. There are steroid creams and stuff they can use, and this is for the rash and the sensitive skin that they get with lupus. Coffee. There again, be aware if they are taking methotrexate, immunosuppressant. Stay away from crowds, be careful of infections. Don't go visit your sick relatives. And sometimes it can also cause some edema, some dependent edema in your feet, some orbital edema in your face. You need to report this to the doctor. It could be some indication of some kidney problems, especially if it's peripheral edema. So you need to stay on top of that. Any questions so far? One more thing for one of the possible complications for lupus is kidney function. It can damage your kidneys. So no more questions on lupus. We will bounce ahead to gout. Gout. Basically, there are foods that we eat that contain purine. Purine, for example, coffee is one of them. Luckily, I don't have gout. Shellfish, meat, different types of vegetables have purine. When your body breaks down purine, it creates uric acid. If uric acid builds up, it can form little crystals, just like little like salt crystals or shards of glass. Well, these uric acid crystals like to deposit themselves in the joints, especially fingers and toes. Big toe always seems to be a real hot target for gout. And when these uric acid crystals build up in the joint, they kind of trash the synovial sac and the cartilage in that joint and create a huge red ball, which they call a tophi. I'll talk about that in a second. It's extremely painful. And it will you'll have episodes of exacerbation and remission where it comes and it goes. I don't think I mentioned that in lupus, but I will be mentioning it in the other ones. They are, these diseases commonly manifest in episodes of exacerbation where it gets worse and then it gets better and then it gets worse and then it gets better, and it just kind of fluctuates like that. My hiking partner, when I was hiking back in California, had gout. He always had to deal with that. And so I had a close friend who was constantly dealing with it. It was manifested in his left big toe. This is the most common inflammatory arthritis we have. Osteoarthritis is probably the other. And there's two kinds. Two kinds are very simple. There's primary gout and there's secondary gout. Primary gout is when you just get the disease itself. And secondary gout is when you get that uric acid crystal buildup as a result of a different disease. So it's a secondary side effect of the other disease, if you will. The only thing I can think of right now that causes a uric acid buildup would be like kidney failure. But primary gout is the most common, pretty common in older adults. Don't tell my friend that. And what happens is you're just producing more uric acid than you can secrete. There is a problem with the metabolism of the purine that causes an excess buildup of uric acid. I tried to look up what that process was, but it was a chemical process this long, so don't worry about it. Important thing is that it's uric acid crystals that build up in the joints. How do we find out? Oh, that's the risk factors first. Obesity tends to hit heavier people. They probably have a harder process or a harder time of secreting the uric acid. Maybe a hereditary component. Alcohol consumption and diet are big factors. I mean, if you're prone toward gout, you really have to watch the alcohol and the diet, because that's what's going to cause it. That's what's going to cause an exacerbation. That's what's going to cause it to flame up. And my buddy, he loved mint juleps, which is an alcoholic drink. So it really upset him that he couldn't drink his mint juleps because he had gout. Kidney failure, there again, that would cause like secondary gout. Kidney failure, your inability to secrete the uric acid, so the uric acid would build up and form crystals. Phalangeal joint pain. Don't you love that word? Phalangeal. It's the big toe disease. Tophi. Tophi is that big red nodule you will see over the joint when the uric acid crystals irritate it. They're very sensitive to heat and movement. It's a very painful process. There again, the ESR or SED rate will be elevated. And there's a couple ways of checking your uric acid. One, serum, which is a blood test, or urine. If either of these is elevated, it could be an indication that what you are suffering from is gout. There's no definitive gout test, but these are good indicators that that's what's going on. And the symptoms of gout are pretty specific. I mean, the tophi and the joint pain are pretty unique. So it's pretty easy to figure out gout. One thing they can do, they can stick a needle into a joint and actually see if you are getting a collection of uric acid crystals in the synovial fluid. Sounds painful, doesn't it? Yes. I think they would only do that as a last ditch measure. I don't know if they suspect that a person's on uric acid, they are probably just going to put them on gout medication anyway and spare you the needle in the joint. But colchicine, probably some of you have heard of that before. Colchicine is the most common medication used for gout. 90% of the time, if they suspect you got gout, you'll be on colchicine. And this helps reduce the inflammation in the joints. NSAIDs, again, reduce inflammation, and also corticosteroids. For chronic onset, for people that have it long-term, ongoing, and it kind of never recedes, there are a variety of different medications that can be taken for that. Allopurinol, you will see that quite a bit. I've never seen febuxostat before, but I do see allopurinol in the clinic a lot. It's not just used for gout, it's used for other things as well. But for those with gout, it just helps promote their body getting rid of the uric acid so that they don't build up crystals. Take it after a meal with a glass of water. Probenecid, I see that once in a while, but very much like the allopurinol, that's helps you get rid of your uric acid, as well as the enzyme pigloticase, which is an enzyme. That's pretty extreme because this is an IV medication. So you have to actually go into a clinic and receive it by IV. And hope your gout's not that bad. I have never seen this administered before. Now, when it comes to education, very, very important. Meats, shellfish, coffee, alcohol, they have to avoid things that have purine in the diet. You can print out, I mean, the internet's full of lists of different food products and how much purine they have in them. So you might want to just like get a sheet that says the top 10 purine containing foods. And so they can put it on the refrigerator and to help remind them that there's certain stuff that they should not be eating. For some reason, starvation diets and fasting, anything that reduces the hydration in your body can aggravate the gout. That's because it's going to make the uric acid more concentrated. And avoid stress. Yeah, right. That's easy to do, right? Okay. Are there any questions on gout before we move along? This disease really isn't debilitating. It's more annoying than anything else. Fibromyalgia. All of us probably at some point have known somebody who has gotten fibromyalgia. Very painful, very debilitating. I mean, it just, it's just like having the flu every day of your life. It's horrible. But it manifests as stiffness and tenderness at trigger points. I'll talk a little about that in a second. It also manifests with chronic fatigue and you just don't sleep well. Trigger points. Here's an example of trigger points. Now, if any of you are or have visited acupuncturists or Reiki massage therapists, they're very familiar with trigger points. And trigger points are usually collections of ganglia or nerve bundles in the body. And these are areas where a lot of your nerve signals go through. And that's the areas that this disease kind of targets. If you look at this, you will see that these are a lot of points that I have seen the massage therapists work on for people under a lot of stress, especially on the back here, the outer lateral area of the elbow, down near the buttocks region. These are all trigger points that I see them use in like Reiki. I know I'm not pronouncing it right, but there again, mostly females, 25 to 60 years old. It is an autoimmune disease, so it's brought on by stress, trauma, infection, other autoimmune diseases. Anything that stresses the body out can cause your immune system to overreact. I'm sure a lot of people will say, our society, most Americans are in a constant state of inflammation because stress triggers your immune system response and creates a condition in your body where you're creating an immune response. So it's very important with these people to get them to relax, use whatever means they can to relax, to reduce the inflammation in their body. Now, we also have a high meat diet in our society as well, and some other processed foods, which also irritate the body and launch an immune response as well. So part of the health problems of the American people on European people as well, is due to our diet and high stress, our bodies are in a constant state of inflammation. And that inflammation eventually wears your body down and can lead to such things as fibromyalgia. There again, just as in lupus, you can have some sleep deprivation as a result of this disease. Moderate to severe fatigue. I mean, we're talking real fatigue here. I mean, hard to get out of bed fatigue. Sleep disturbances, headache, depression, memory problems. Things are fuzzy. Things are real fuzzy because of the disease. And this can also affect your digestive process. There again, we don't have a fibromyalgia test. It's mostly a differential diagnosis. Let's eliminate those things, and probably what we have left over will be fibromyalgia. That's why it's very difficult for doctors to diagnose. What can we do for them? There again, we treat the symptoms. We treat the pain, we treat the mobility, we treat the fatigue, and offer emotional support. The depression is a major factor with fibromyalgia, and it's really not a symptom of the disease so much as it is a byproduct of the disease, because it wears you out and can cause depression. There are some drugs we can give that will help. Serotonin, norepinephrine reuptake inhibitors. Some of you have probably heard of SSRIs, serum serotonin reuptake inhibitors. Those are things like Prozac. I can never remember Prozac. Prozac is an example of an SSRI. And what happens is serotonin makes you feel better. Dopamine and serotonin are two enzymes, two enzymes in your body that just make you feel good. So what this does is normally serotonin will be secreted by a nerve, and it will attach to the receptor nerve, and you get that elation, and then it disconnects and it digests and disappears. Well, when we're talking about a reuptake inhibitor, what we're talking about is the nerve that secretes the serotonin. It hits the other nerve and and then it releases. And instead of the originating nerve digesting the serotonin, this reuptake inhibitor blocks it from being digested so that the serotonin hangs out in that gap longer and provides hopefully a better feeling of well-being. This particular one, it does it not only for serotonin, but also for norepinephrine, which will also elevate your mood. So what it's basically trying to do is it's a mood elevator to help you feel better and hopefully treat the depression. As with all mental health medications, you should not drink alcohol with it, and it can cause some drowsiness. So if they're going to drive, what you want them to do is try the medication and see how they feel. If they're sleepy or woozy, they should not drive. But if they can take it and then they feel okay, well, after a day or two of taking it, and they realize it doesn't inhibit their driving, then they'd be okay to drive. So serotonin and norepinephrine reuptake inhibitors, SNRIs and SSRIs, you will see that a lot in your mental health medications. NSAIDs again for inflammation. And there again, tricyclic antidepressants, amitriptyline and normotriptyline and trazodone. Actually, I've seen all three of these medications. They are to just help with the mental status, to help elevate the mood and help the person feel better. They are mental health medications. They can cause drowsiness, especially trazodone. You can get really kind of whacked out on trazodone. So be very careful with those medications. Education. We don't want them drinking a lot of coffee, alcohol, Red Bulls, energy drinks, any of that stuff. That's all going to interfere with their sleep process. They want to continue to exercise. Exercise will help produce the serotonin and norepinephrine that will help them feel better. And there again, to keep the inflammation process down and reduce their body's inflammation process, anything that helps them relax. Yoga, medication too, but meditation, stress management, anything to just get them to relax, to reduce that inflammatory process going on in their body. Big fan of meditation. Meditation will do a lot of great things for you. Any questions on fibromyalgia? It's one of those very elusive diseases, but I see a lot of women when I get their medical history in the hospital, they will mention fibromyalgia. I personally, I think it's another one of those byproducts of our civilized world. But I'm not a doctor, so I can't say that. One last one, rheumatoid arthritis, and then we'll be done. That I can get you out of here and you can get on to your orientation. Rheumatoid arthritis is a progressive disease that's going to get worse and worse and worse. It can damage the tissues in your joints, cause inflammation and deformity. Well, I'm sure you've all seen people with rheumatoid arthritis. Their fingers normally go off at an angle. Their joints are big and swollen. It's really, I've known I had several friends who've had rheumatoid arthritis. It's really a debilitating disease. And it's really a shame that we don't really have a good cure or treatment for it at this point in time. What happens in rheumatoid arthritis is your immune system, your white blood cells are basically attacking the connective tissue in your joints. Your synovial sacs, the cartilage, it's literally eating away at that tissue. You will have bouts of exacerbation and remission, but it is progressive. It will get worse and worse and worse. It can also affect other connective tissue in the body. I don't know exactly what it is that people with RA eventually die from, but it can shorten their life. There again, females, when it comes to immune system diseases, the females drew the short straw on that one. 30 to 50 is the most common. Most women I've known who developed it, they're usually in their 40s. It can come after you have an infection. And that's what happens is you get an infection of something. And there again, we used to think it was Staphylococcus aureus, which was the primary culprit. But they've since found that it's not always necessarily staph that causes it. But that infection will cause your immune system to go into hyperdrive. And then once it goes into hyperdrive, we can't get it to shut down. And evidently, the MHC1 little ID indicators on the cells on your connective tissue evidently is very similar to some viruses and bacteria out there. So that's what your body goes after, is the connective tissue. There may be a genetic link with RA coming down through family lines. Fatigue, pain, and stiffness in joints. There again, I was saying it affects connective tissue. So there is connective tissue in your lung area. It can make breathing difficult. Pleuritic pain. Pleuritic means it hurts when you breathe. So if you know somebody, for example, that got a cracked rib, they take a deep breath, they feel the sharp pain in their chest. That's pleuritic pain. That's kind of nice to know, because if somebody comes in and says, I'm having chest pain, it's okay, is it your heart or your lungs? What happens when you take a deep breath? It hurts really bad when I take a deep breath. Well, that's a good sign, because that means it's probably your lungs and not your heart. Anyway, getting back to the point, joint swelling and deformity, and you get those big, excuse me, you get those big nodules on your joint from the inflammation and the soreness. They kind of look like the tophi from the gout victim, and the low-grade fever because your immune system is in hyperdrive. Low-grade fever is a really good indication, especially when you have fatigue, joint pain, and low-grade fever. Those three are a really good indication that you're dealing with an autoimmune disease. Different tests. There are a whole slew of anti-CCP antibody tests. I didn't want to list them all down here for you. I've never seen this test administered, but it's out there. They're basically looking for some of the common antibodies that are a result that are created when a person develops rheumatoid arthritis. But there's also an antibody, there's an RA factor antibody test. The antibodies attacking the body, your joints in a person with RA has a certain factor in the antibody which they can measure. And this is a good clue that what the person is suffering from is rheumatoid arthritis. So that when they launch an antibody and when those B cells start spewing out the antibodies, there's one little factor in there that indicates that it's probably RA. There again, SED rate and CRP test, I've seen those around before, can be elevated. That may indicate, again, an autoimmune response, just like it does in lupus and fibromyalgia. And elevated WBCs. I mean, you have an immune response, right? So your WBCs are going to go up. That's just, that makes sense. There again, they could do an arthrocentesis. In other words, they stick a knee into the joint, into the synovial sac of the joint, extract some fluid, and look for that RA factor that I was talking about on the antibodies in the fluid to see if it is indeed rheumatoid arthritis. X-rays will usually only show at the very progressive stage of RA, because you will see the joints be they lose their cartilage in between. You get bone on bone, you get swelling, you get irritation. It shows up very clearly on an X-ray. But I mean, you're kind of progressed far into RA by the time it starts to show up on the X-rays. Kind of pretty easy to see without the X-rays, so not sure why you'd want to order it. What can we do as nurses with people with RA? Encourage movement and activity. Any form of arthritis, be it rheumatoid arthritis or osteoarthritis, you want to keep the joints moving. Keeping the joints moving creates fluid, which helps the joints to keep moving. Sitting still is the worst thing you can do because the joint fluid is not produced and the joints will stiffen up and it'll make it that much harder for them to move. Fatigue, you just kind of have to monitor that, make sure they don't overdo it. Physical therapy and occupational therapy, as the hands get worse, it's more and more difficult to grab things, hold things, open jars, cook. There's a variety of tools and techniques that both the physical therapist and the occupational therapist can use to help them in day-to-day life. The physical therapist will help them keep their joints moving. The occupational therapist will help them with daily skills so that they can continue to live on their own with the disease. Also, as a nurse, you want to make sure that you monitor their medications, make them aware of the side effects, make sure they stay on a regular schedule. Now, we are going to look at some of those medications. The first two we've already talked about, NSAIDs and corticosteroids, so I won't go into those at all. But there's also a couple drugs that are unique just to rheumatoid arthritis. COX-2 enzyme blockers. These are designed to try to slow down the debilitating effect of the the antibodies and the attacking of the body against to kind of block the immune system response, I guess is about the best way to put it. Silicobits, I have rarely seen that in the hospital, but I know it's out there. Thing you have to watch out for is it does cause some GI distress. DMARDs. DMARDs are the big thing for rheumatoid arthritis. This is if it's progressed quite a ways. And they're actually, DMARDs is a term for a group of drugs that are used quite often in combination with each other to try to slow the process of the rheumatoid arthritis. Now you'll get the anti-inflammatory effects from the hydroxychloroquine. And there is this particular antibiotic that they use to try to counter the body's reaction. Try to slow down the it's not really killing the antigens because there really are no antigens per se, just your body's own natural indicators. So it's blocking these antibodies from attaching to those markers on the cell. There again, methotrexate, a immunosuppressant drug. So both of these right here are just trying to slow down your body's response and a immune response against the joints. What can we do as nurses? We can apply heat or cold to the joints. People often ask me in the hospital to say, well, which is better? And my response is, what feels better? Sometimes if the joints are stiff, the heat helps you to move them. If the joints are inflamed, then the heat's not going to feel good because of the inflammation. So in that case, the cold will help the swelling to go down. It all depends on the situation. And usually I just leave it up. The patient's going to know which one's going to feel better for them. Conserve energy when they're having bouts of fatigue. There again, it kind of comes and it goes. And be sure that they are up to speed on when they should take their medications, what side effects to look for, and just to let you and the doctor know if they are being effective or not. That's it. Any questions on rheumatoid arthritis?
I have a question.
Sure.
So if a patient that has RA and they're on Humira or prednisone, and there's like an increase of thrush, is that a side effect of the prednisone? But the patient hasn't received or hasn't had thrush until they started the Humira. So is there like a drug on drug interaction there, or?
Okay, they have an increase of what when they?
Thrush.
I'm sorry, you got cut off on the mic there.
Thrush, a thrush of the mouth.
Stress?
Thrush, isn't
Thrush.
that
Oh,
candidiasis?
yeah. I believe that to be a side effect of the prednisone.
Oh, okay. Okay, thank you.
Now, if I'm not mistaken, I'd have to go back and look at it, but I think thrush also occurs quite often with like antibiotics, because your body is trying to the antibiotics kill off all your good bacteria and stuff too, which kind of keeps things like yeast infections and thrush away. So I'd have to do some more research into that, but that would be the prednisone would be causing that, not the RA.
Okay, that makes sense. But it would occur at that type of side effect is something that could happen later in time after stopping on prednisone for, let's
Yes.
say 2 years. It could be something that just develops. It wouldn't be from taking like the Humira all of a sudden. It wouldn't be effective because of the Humira, or just something that can happen.
You know,
over time.
I'm not sure. I don't off the top of my head know all of the side effects of the Humira.
Okay.
So I'd have to look that up and research it.
Okay. Thank
But
you.
the thrush is real easy to treat. We have a mouthwash that we give them for that. It usually gets rid of it pretty easily.
Yeah, it's just that it keeps coming back. So it's
Does it?
strange.
Okay.
Yeah. So I wondered if it was due to the Humira injections, because that's something that's new. So
Yeah, I'm not familiar enough with the side effects of Humira to know if that is one of their side effects or not.
okay.
But I can look it up.
Thank you for the information.
Sure. I think people on antibiotic, trying to think of those patients I've had with thrush and what kind of medications they were on, but I can't think of it off the top of my head. Any other questions before we go? Or I'm going to stop the recording.